Where'd you go down here? Did she say?
Thank you, everybody, for coming back so promptly.
Go down there.
Yeah.
Thank you very much for coming back so promptly. And I'm sorry I was interrupting sort of very vivid conversations. But hopefully it means that lunch, you'll get your proper lunch break. And also we've got discussion as well. So I'm going to start the next session. And Naledi Kline, Head of Nursing Standards, is very kindly going to set the scene for us in respect to the next session of early intervention. Naledi, over to you. Thank you very much.
Thanks, Elizabeth. Can you hear me? Can you hear me? Yes? Can you hear me at the back? Thanks, Elizabeth. Morning, everybody. I think it's still morning. We are talking about early intervention and health visiting, and it just felt like a really good idea to get the actual clinicians and the parents who've been part of the process to do the talking rather than me. So I'm going to hand over to Joanna, who's one of our early intervention health visitors. Although it's Guy's and St. Thomas's, as you know, we are split into Lambeth and Southwark. The early intervention health visitors are on the Lambeth side. We've got a very small group of 7 early intervention health visitors, 2 of whom job share. And I'll let Joanna talk you through the next steps, and I'll be on the panel later to answer any questions.
Okay. Early intervention. As Naledi said, there are 7 of us working on the Lambeth side of GSTT, and we have 3 localities. So we split between the 3 localities, and between us we cover the whole of Lambeth. Definition of early intervention. We get we get a vulnerable pregnant woman referred to us by midwives, the psychiatric team, GPs, other health visitors, and we make early contact with them. So it's very important that we make early contact with these mothers. So as soon as we get the contact, the referrals, we have 7 days to make contact with the mothers. So within the 7 days, we ring them, we make an appointment to see them. We go, we introduce ourselves, we talk a bit about our role, and we read the obstetric notes, and we do our own assessment, and then we identify any risks that the family may have, which I'll talk more about that later. So that early contact is very, very important because it's established a relationship with us, and also for the early identification of any problems that the parent might have. It also introduces us to the father as well. Oh, sorry. And then we work intensively with them. Usually we do 1 weekly visit for the first 8 weeks. And then it's 4 weeks, every 2 weeks for 4 weeks. And then every 6 weeks until the baby is born. And then when the baby is born, we go to the hospital to see them. When they come home, because we know whatever problems they may have already, and we've signposted them to the appropriate agency, it's easier for us to work with them. And also in the postnatal period, any new risk or any new problems that comes, we deal with them. We work with them from pregnancy to 2 years of the child's life. So I have a client here who has just turned 2 years, and we're just going to discharge the family to the generic health visiting team. Okay, as I said, sources of referral. We get our referrals from health visitors from MAPIM, which is the Maternity and Perinatal Partnership in Mental Health, which is based at St. Thomas's. And they are the mental health team that oversee all the mothers with mental health, drug and alcohol issues. We also get referrals from the teen phase midwives at St. Thomas's, and they are midwives especially put together to work with teenagers. So we get a lot of our referrals from them as well. We get a lot referrals from CYPS, which is the Children and Young People Services, the social services that children who are at risk of significant harm or children who are already on the child protection plan. We also get referrals from managers of children's centers because any problems or any risk that they identify in any of the mothers who are using the children's centers are automatically referred to us. We get referrals from the perinatal unit at King's College, which is also a psychiatric unit, and they deal with both young and adult drug, alcohol, and also mental health issues. Because some of our mothers live in Balam and they share St. George's Hospital, we get some referrals from St. George's if the mothers are resident in Lambeth. Most of our referrals also come from the community psychiatric services, which we work very, very closely with because most of our mothers have mental health issues. And also we work closely with the family nurse practitioners because they are capped at 25 clients per professional. They get full quite easily, and then we just mop up all the referrals that should have gone to the family nurse practitioners. The role of the early intervention health visitors. Our role is just the prevention of child abuse in the sense that the services, the strategies that we put in place to work with the mothers prevent child abuse or prevent children from significant harm. And we safeguard the children by providing an early help services to support the children and their families at the softer end of the child protection and safeguarding. In other words, the interventions that we do with the families prevent children from going on the child protection register, and then those who are on the child protection register, when they refer to us, come off the register as well. Our overarching aim is to work with parents and their children to enable them to achieve their full potential, because we're looking at every child has a potential to be somebody. So we work with the mothers, we plan groups that we set up for the mothers and work closely with the children's centers and the other professionals as well to ensure that every child has can reach his or her full potential. We also help and support to change behaviors of both the mothers, the parents, and the children, and so that they can be the best for the parents, so that they can be the best we can. We work with the skills that they come with, their cultural beliefs, their religious beliefs, the skills that they've learned from their parents, and then we work with them to make them be the best parents they can for their children. And also we help them meet their children's physical, emotional, mental, and social needs. How do we achieve this? We achieve this by the four main areas of working as per the Health Visitors Implementation Plan. That is through community services, that's with the GPs and all the services that come with it. Universal services is the generic health visitors who see the mothers without too many complex needs. And then they run the child health services, they do the new birth visits, they do the developmental checks for the children, they make sure that the children are having all their immunizations at the right times, they are attending clinics, they are assessing the children's centers, which is very important because we want the children to interact with their peers. Also, for the children's centers, they're very good at play and stimulation, and this helps with the children's social and developmental plans. It also eases social isolation, so their role is to encourage all the mothers in their caseload to attend the children's services. We also have services for fathers because we always include fathers in what we do. We have parents groups and also we have fathers only groups. The Universal Plus services is the early intervention work collaboratively with other services like mapping, like the perinatal teams, like social services. And most of the clients we have are either on the CP plan or they are child in need or look after children. And we run so many courses. We run triple P, we do the postnatal group, we run antenatal clinics with the midwives so that they can get to know us. We can identify any problems and also they can get to know our role before they deliver. And we work closely with GPs as well. The Universal Partnership Plus services is the ones with complex needs like special needs, educational needs, physical or otherwise. Excuse me. And they work closely with Mary Sheridan, where our group of community pediatricians, the speech and language, the pediatric dietitians, and the pediatric physiotherapists work together. So we meet regularly to work and plan the care of these children with vulnerable children with very complex needs. Our special focus is on triple P, which is the positive parenting, because most of our clients have come with so many complex issues. Parents is a very big issue for them, and there are a lot of childhood behaviors. So we run the triple P. Okay. We run the triple P, which is a 4 weeks course that encourages them to be the best enough parents that they can. I haven't got much time, so I have to risk it. We also run sleep clinics, which is another thing that really gives moms some problems. We use baby massage to teach mothers that touch. Some of these mothers have come from background with sexual abuse, physical abuse, and we use baby massage to teach them that touch can be good and loving. It doesn't have to be painful or controlling. So I just have to risk through this quickly. So the triple P is we focus on ensuring a safe and engaging environment, creating a positive learning environment, using assertive discipline, focus on attachment, having realistic expectations, and taking care of themselves as parents. The benefits of our role is that it builds confidence and early access to all services for the service users. Increased antenatal contact includes individual care planning, continuity into the postnatal period and the first 2 years of life. Increased breastfeeding rates, because we with them all the time. From the antenatal, we talk about breastfeeding, we support them, so our breastfeeding rates are very high. 100% uptake of immunizations and health reviews, because we do it all ourselves. Reduce A&E attendance, because we talk about home safety and then parenting and all that all the time. Reduce rate of second pregnancies in teenagers, because they learn to control themselves, they take care of themselves, and they make the right sexual choices for themselves. And then intensive and preventive approach ensures continuity of contact and improved working relationship. Also, reduced rate of maternal mental health, because we work with them all the time. Reduced risk of existing mental health illness worsening. Increased potential for families to protect their children and themselves from risk of significant harm in the long term. And it's also cost effective, as fewer failed appointments lead to effective use of time. And also, most of our children either come off the CP plan or don't go on the CP plan. Barriers to our role. Negative association with the health visiting team of some families prevent them from accessing our services. Lack of confidence in the NHS as a whole. Low self-esteem, and most of our clients have very low self-esteem and low confidence. And the feeling of powerless, because some of them come from a domestic abuse background where the partners are very controlling, so they dare not access any services. Language barriers is another barrier to our role, and also fear of the unknown. Most people think that once there's an early intervention, it means that automatically the child is going to be taken into care. So that prevents some people from accessing our services. And then clients from no recourse to public health, they don't, asylum seekers, refugees, some mothers with drug and alcohol abuse don't engage with us. Positive outcomes. We have a very high quality integrated range of early intervention services for the vulnerable families on the tool and their parents. And as I said, we run a number of structured courses for all the mothers that are in our care. And then we plan and manage our caseload because we have a very small caseload. Our minimum is 35 families, our maximum is 55 per early intervention health visitor. Also, we have the increased contact that we have with the children and their families, safeguard and promote welfare of vulnerable children and families, because the mothers are able to make choices that will protect their children from the risk of significant harm. And also, we identify and manage risk. Effective partnership working across children's centers, effective interagency partnership working, and then very good communication as well with other agencies. And then reintegration of teenagers and young parents to mainstream schools. Most of our teenagers, like those from 14 to 15, always reintegrate back to mainstream schools without any problems at all. And then regular attendance of vulnerable families at short courses run by children's centers has led to increased self-esteem and self-confidence in the parent users. Most of the children's centers run short courses for the mothers, literacy skills, self-esteem skills, social skills. That has really empowered the woman to be more assertive and to take care of their own lives rather than let somebody else do it for them. And I've got Miss Watson, who has been with me, she was referred to me from a mother and baby unit when her son was about 3 months. Yes, and she has been with me.
Give a big round of
And he has just turned 2, so we'll be discharging her to the January team soon. Yes.
So welcome. And
Thank you very much. Thanks. Hi, everyone. My name is Shanika and I'm 20 years old. My son is 2 and I live on my own. Before this, I lived at Jennings House Mother and Baby Unit where I first met Joanna, the health visitor. And my son was about 4 months at the time. Joanna visited the house every 2 weeks where she monitored my son's health and weight and set up GP appointments where necessary. She also encouraged me to pursue my interest in becoming a midwife, and I'm pleased to say I am awaiting September to start my access to nursing course, and then from there I would like to become a midwife. Yeah, that's it. Thank you very much.
Would you like to take Shanika, come and sit?
Yeah.
Yeah, after this. Okay, come sit with us and then after you, colleague, we'll be happy to take questions and comments from the audience.
So,
Okay, I had to refer Master Watson to the second divisional eye clinic because of double squint. And also, this is one of the roles of the early intervention, and also for an undescended testicles. So she's now under the care of St. Thomas's for these 2 things. Then I've got Miss Cox. I had she was referred to me via social services when she was pregnant because she.
welcome.
Because she there was some family. She ended up in care for a short while. She needed to have counseling, and there was broken relationships between her and her mother. But through the services and the intervention, she and her mother are very close. She visits mom visits her as well. And there has been no identified problems with her parenting skills.
Uh, Hi, hello. I'm 19 years old. I'm Lily Rose, my
Sorry,
child.
she had a slight speech impediment, so please bear with her.
Lily Rose is 8 months. Joanna helped me a lot since she's been around. She comes to Jordan's house, mother baby unit, every 2 weeks. I find it useful when she comes because if I have any problems, I can talk to her at the time. I've recently been discharged from social services. While I was with social services, she has been supportive and most of all, caring.
Just to say that the baby was never put on the plan, and she didn't even become a child in need at all. And okay.
We have a discussion.
Just 1 minute, just finally, please.
You haven't finished yet. You haven't
Oh,
finished.
okay.
Let's allow
sorry.
have a seat, and because I think we're all, thank you so much for standing up in front of the audience, and your children are following in your footsteps. They're participating as well. Thank you so much indeed. So, would anybody like to comment or that they would like to address to our parents who've very kindly come to talk with us? This lady, thank you.
It's about the early intervention project. You mentioned that you mop up where FNP, their caseloads are too heavy. Do you?
25. An FNP practitioner. So after they've got their quota, then we take up all the rest.
So that's quite a lot, but you've got a wider admission criteria, obviously, to your service.
Yes, we have, and we work closely with them, but theirs is quite different in the sense that our criteria is much wider. They deal with normal teenagers. We take normal teenagers with complex needs, as well as mothers with mental health, and they don't have to be teenagers, and mothers with drug and alcohol misuse, or partners with drug and alcohol, and also domestic violence. For us, our criteria is quite different from theirs. Is quite straightforward.
Lady at the back, thank you.
Can I just ask if you had a young lady that wasn't referred to you till she was almost term, do you take those families as well?
Yes, we do. Sometimes we get them because most of the pregnancies are concealed, so they end up in A&E. They're taken to the ward, they deliver, and then the midwives will refer them to us before they discharge, so that we go and we assess them on the ward, and we have a discharge planning meeting with them, and we refer them to the appropriate agencies that we feel that, depending on the needs that we've identified. And then all professionals will meet and have a meeting on the postnatal ward before the client is discharged, so that every professional knows exactly the service that he or she is going to provide for the teenager.
Could I ask a question of Miss Watson? You're going to hopefully do midwifery. Is there anything that you've sort of learnt from your experience, or the service that we've heard about, that will remain with you when you're a midwife, that will help other parents, do you think?
I think firstly it's like patience, and also learning to kind of be a mum and then still have the will to do what you want to do. Because being like getting pregnant, that did kind of put me off, but then I realized I still can do what I want to do while having a baby at the same time.
Good. Thank you very much indeed. Thank you. This lady here, thank you.
Watson, now you're going to be stepping back to universal health visiting services. It's obviously going to be a big change, and I just wanted to ask, how do you feel about it, because you're not possibly very likely to see a health visitor. So
She will. She will.
Well, I'm aware of it. Yeah, I'm just actually looking forward to it. I'm up for the challenge. Yeah. A lot of support as well.
But also, her son has got full-time nurse replacement already. You know, that is part of the package for her return to education.
Part of the service is about empowering new services for them to grow. And part of what you're doing is connecting them back to
Universal services. Yeah.
hopefully by the second year of life, they're more confident in the services, you've got education, we're funded 2-year-olds. So hopefully, you know, you'll be confident using all the services that are available.
And also, you know, they are very proactive in assessing, you know, services for their children. They always put the needs of their children first. So they especially the teenagers, I find that are very, very proactive in protecting their children. So they will assess services, you know, as soon as their child is not well, they first to go to the GP, because every time they go to a GP, we are informed.
Thank you. This lady and then this lady. Thank you.
I think it was the approach at first. They were kind of teenage friendly at the time, and they understood us. And I think it was just the easy approach to get us involved as well. And when you're pregnant, you do feel vulnerable and you need help. So when you're pregnant and when you have a young baby, you are likely to go to them for help.
I think somebody, was there somebody over here? Sorry, thank you.
Yeah, sorry, my name's Rose. I am a health visitor. I just wanted to ask Shanika, I think it's absolutely fantastic. The confidence from both of you comes across, and whether the input from Joanna and her team helps you in your confidence as parents, and whether it had an influence on you making your choice to go into midwifery.
Because I was still undecisive about whether I wanted to do it since having a baby. I was like, oh, should I wait a while? But then she was like, go for it. And then since then, I started applying to colleges. And I used to tell her, yeah, I didn't get through in this one. I'm going to try a bit on this one. And since she used to be a midwifery, she used to be a midwife, as well. And she's now doing health visiting. So that encouraged me. Oh, I can always change career and do something else. So, yeah.
Well done, Joanna. Wow. Guys.
Dave, at the back.
Yeah, I just wanted to say, once you've become a midwife, don't forget you can then also train to be a health visitor.
There's a lady at the back, please. Thank you.
Just very quickly, I just wanted to know what percentage you have of non-engagement of families.
I would say about 2%, very, very small. Even those, they wouldn't, it's not completely, complete non-engagement. They would engage and then they would disappear off the radar for some time, then they would come back. And these are usually the drug misusers, because they those that move from crack house to crack house are the ones that, disappear off the radar for some time. But then they always come back, because they will always come back for the sake of their baby, because they want to protect, because they want to protect their babies. They would come, but they might disappear for about 6 weeks, and then they will ring and say, because I haven't seen you for a long time. So then we pick up the service again, and then that's how it goes. But once they deliver, then somehow the babies always turn their lives around. Then they start engaging fully.
I mean, the other thing that's happened with early intervention that they've noticed is that some of the mums, I mean, and they will say themselves, they then provide support for each other, you know, so, and they will say, oh no, you don't have to put up with that, do this. And so they sort of gain from each other as well. It's not just from the health visiting service, it's also from each other. They provide, there's a support group in one of the children's centers.
Yes, in the mother and baby unit where they are as well. They all support each other. And if somebody is doing something that is not right, one of them will ring because they have my telephone number and say, oh, I felt that maybe the water that she put in the bottle was too much for what she should put. Can you ring her? But don't say I said.
Whistleblowing.
And they also exercise. They have a DVD that they exercise in the lounge. And they really look after each other. They do a lot of walking. So they use walking as a form of exercise. So they are all very fit and very, very slim.
Okay, the last, one and then two short inputs. Thank you. Funding?
It's from GSTT. Originally, it was from the Lambert Council, but for the first 3 years. And then the GSTT, when we are at Lambert, amalgamated with GSTT, they took over the funding. So we come under GSTT. We do.
And I think we've seen some figures from our speaker that there's certainly some very, very good positive outcomes, I think.
And we also do, quarterly monitoring form.
Thank you. Thank you. The last, yes, please. Thank you.
Yeah, it was a similar question, sort of why it was only set up in Lambeth rather than other boroughs, or sort of how it got set up there, and whether it's going to be sort of rolled out to other boroughs.
Could you put your microphone on, Edith, please?
We were looking at doing something about intervening in families where we felt that women, teenagers, women who had significant
you can take your finger off.
Oh. Can you hear me? Finger don't work. And we looked at some research, and it was led by somebody called Alan Heath. He was a psychologist, and we looked at some key interventions make a big impact on children's lives, and we decided we'd start from the antenatal period. They did some research in Australia and in Canada, and we set up the early intervention service with 3 health visitors. And the background to that was 3 clinics, really, as well as the training. It was a crying, feeding and sleeping clinic, because we felt they were the trigger factors that got in the way of the parent-child relationship. And the other thing was early contact in the antenatal period. And one of the key questions we asked was who's going to be with you at delivery and who's going to help you after the baby's born. And it then set in a chain of investigations and inquiries, and it's grown today to 6 health visitors, and I hope it will grow more. I'm absolutely proud of the service, because we envisaged that this is how it would be at the end. We'd have mums who
Yes. Well, I think Watson thinks he's on Britain's Got Talent. Seriously. Because he's really doing his stuff there. Can I ask the last question, if you don't mind? You said something really interesting, that the staff were teenage-friendly. In what is teenage-friendly? Well, or maybe what is not teenage-friendly?
Just their approach in general, like they understand where we're coming from as a young mum or as a young teen that's pregnant, and the issues we can go through, and the way we can kind of, like when you're pregnant, you kind of feel, oh, I might just still do what I want to do. They know what you're going through in a sense, and they push you to, you still need to, and then they give us sources and encouragements to still do what we want to do.
Thank you very much indeed. Can we give a huge round of applause to everybody? Thank you very much. Thank you very much indeed. I think I'm going to be really tough now because... Oh, last slide, one slide. Sorry, I know that sounds awful, but...
Okay, and then, so with the key to our role is record keeping, which the last keeper just beautifully, told us. Finally, I want to leave with this quote, which sort of motivates us because we do face some challenges, especially when we can't find some of our clients. That if you are thinking a year ahead, sow a seed. If you are thinking 10 years ahead, plant a tree. But if you are thinking 100 years ahead, educate children. Okay.
Thank you very much. And can we also give a big round of applause to mums and children? That takes a huge amount of confidence to come and present in front of, there's 60 people here. So thank you very much indeed.